Mr. Ish, an aircraft maintenance engineer working with MAS from Iraq, when I saw him in my hospital, was way back in 1997. He was brought in by ambulance from KLIA with acute inferior wall myocardial infarction via the ER. We doctors mostly differentiate a heart attack by denoting either it involved the inferior wall or the anterior wall. The inferior wall myocardial infarction is due either to the total occlusion of the right coronary arteries or the left circumflex branch of the left coronary artery, which supply the left posterior segment of the left ventricle. An anterior myocardial infarction is merely the total occlusion of the left anterior descending artery supplying the left ventricle in the anterior front segment. A massive anterior infarction is due to the total closure of the left main artery, whose branches are the anterior left descending artery and the left circumflex artery, which supply the posterior part of the left ventricle. Needless to say, the total occlusion of the left main artery carries a high mortality risk. Oftentimes, patient dies of cardiac arrest or cardiac standstill before even reaching hospital. Back to our Mr. H. He was admitted then in 1997 with a view for primary infarct angioplasty and stenting at the point of acute myocardial infarction. At angiography, his right coronary artery was found to be totally occluded in the proximal segment. At that point in time, drug-eluting stent was still not yet available, so I implanted a bare stent from Israel known as the NIR stent, NIR, NIR stent, a very damn good stent. He was discharged well on the third hospital day. Clinic follow-up involved optimization of his hypertension control and bringing down his LDL cholesterol or bad cholesterol to the floor, that is below 1.8 millimole as a target. Lo and behold, 11 years later, Mr. H was readmitted, this time via my outpatient clinic when his stress test was noted to be strongly positive. At coronary angiogram, he had a long, tight narrowing in the left circumflex artery. I duly implanted a Zion's drug-eluting stent, and he was discharged the next day. He continued to be regularly followed up in the outpatient clinic, and in the interim period he developed diabetes. Then, a year ago, he was admitted again for an outpatient when an outpatient stress test was again very positive. This is around 12 years after the second angioplasty and stenting to the circumflex artery. Angiography showed that, alhamdulillah, the stent in the circumflex artery and the right coronary artery were fully patent. The new lesion was a subtotal or a 99% occlusion of his mid left anterior descending artery. As standard technique, I passed a guide wire pass through the narrowing in the left anterior descending artery and able to balloon the lesion. Then a long drug-eluting stent was carefully positioned across the lesion in the left anterior descending artery, and the lesion was dilated, and then the stent was implanted at high pressures. After the stand balloon was removed, a shorter non-compliant balloon was implanted into the stand and deployed at higher pressures to ensure proper opposition of the stand into the wall of the artery. In summary, I can surmise that ischemic heart disease is a chronic, relentless disease. We cardiologists manage our patients by encouraging them to eat well, to keep their weight to the ideal weight regime with regular exercise, and we treat their diabetes and hypertension optimally. Even with this careful approach, disease progression occurs, either with new lesions in new segments, as in Mr. H, or within the already implanted stents, even under. Needless to say, of course, that we insist, we interventional cardiologists insist that all our patients have to stop smoking, indulge in regular exercise, and to maintain to ideal body weight.